everyone for joining us today for an exciting and educational webinar titled How to Improve Health with Hormone Therapy. I am very excited to introduce our speaker, Dr. Thierry Hertog. Dr. Hertog practices his medicine in his clinic in Brussels with his sister, Dr. Teresa Hertog. They proudly represent the fourth successive generation of physicians working with hormonal treatments. Dr. Hertog devotes his life to the promotion of a better, patient-oriented, and evidence-based medicine. He does this by working in two directions. First, by collecting scientific data on therapies that may improve the quality of life and health and increase the human lifespan. The information obtained is transmitted to other physicians through medical conferences, books, and articles, videos, radio, and TV. Secondly, by carefully studying any potential treatment risks and teaching others how to minimize these risks and therefore increase the safety of the therapies. Author of numerous books, Dr. Hertog also travels a lot to take part in numerous conferences and congresses throughout the world. He co-organizes many of these specialized gatherings and holds important positions in several international and national medical organizations. He is the president of the International Hormone Society and of the World Society in Anti-Aging Medicine. Dr. Hertog will address questions at the end of the webinar. Please enter your questions in the Q&A button located on the toolbar. Without further ado, welcome, Dr. Hertog. Please begin when you are ready.
Thank you, Lindsay. Thank you, and thank you for the attendees who are already there. So this webinar will actually be also an introduction and a workshop I will give the 20th of February. And so you get a lot of clinical pearls that you will see interesting. And we'll also even talk about nutritional therapies and how they can improve our health. And so basically, we're going to talk about how to improve immunity, energy, and sleep, and how to reduce inflammation. We're in this COVID crisis for the moment. And actually, everybody has problems with immune system that should be better, energy that is often not as good, and sleep not being as good as before with all the anxiety we have all around. And there's a lot we can do in a natural way. And I'll show you actually with nutritional therapies and hormone therapies. And then specifically also to reduce inflammation. So let's go. To improve health, I think the first thing is that we need to increase energy. If you have more energy, even your metabolic reactions will be improved. And so in the workshop I will give on 20th of February for the A4M, there will be a 1-hour discussion on how to improve energy. And I can tell you it's the result of a literature review of the last 40 years, but a lot is experience-based. So that means it works. What I say, you can test it and you can try and you will see that generally it works. So when you have fatigue in a patient, you need to examine when the fatigue comes, because that will often give you an insight to what is the cause. And the fatigue can be just in the morning at wake up and then it gets better during the day, or it can be in the afternoon, or it can be in the afternoon and evening, and each time there's a different deficiency causing that. And so that you know already that the patient will improve in 90% of the case or 85% of the case when you correct that deficiency, even if you didn't do a lab test. Of course, I always propose additionally to get up a clinical examination to do lab tests so you really get more sure of your diagnosis. Evening fatigue also specific when it just comes up in the evening, has specific cause. Whole day fatigue has several different causes, and we'll see some of those now. And the lack of sleep can cause also, of course, fatigue, stress, sports. People can be tired only when they do sports. That must make you think something, must put a light on in your brain. At rest, standing up fatigue only when you stand up, always different causes. Inability to recover, exhaustion. It's not psychological. Please get out of your mind. If there's fatigue, there are generally hormone and nutritional causes and also burnout has specific hormone and nutritional causes. So let's look at what happens when you have estrogen and testosterone. These hormones, these sex hormones, actually give off energy that is there the whole day. So if you're tired the whole day, suspect that there's deficiency there. So there's a permanent fatigue, moderate fatigue, but present the whole day at the same intensity. That's typical for the estrogen deficient fatigue if it comes up in a woman. So it's not a severe fatigue, but it's there all the time. And here, for example, there's a study where we're giving a birth control pill. And what do we see? That when you give that to women younger than 35 years, these women generally have enough female hormones. Well, it does give some better health scores. They may feel better because they're getting a sort of addition of female hormones, but it doesn't really improve energy or the quality of life perception. But if you give the same type of pill to a woman 35 years older, when the female hormones are already starting to decline, what you see is that there is definitely more vitality in these women with the pill or general health scores. So depending on the deficiency a person has or on the age, which is generally associated with deficiency, female hormones can give better energy levels. Testosterone deficient fatigue in men and women actually is also background fatigue all the time, a constant fatigue, but it worsens when there's physical exercise or physical activities. So it's really a sports fatigue or physical activity related fatigue that is then increased in that case if you do not, as a woman or as a man, have enough testosterone. And so when you give testosterone treatment to men, several studies show that it does really increase vitality here. Here is with weekly shots, 4 weekly shots of testosterone. That's actually an insufficient dose in almost any male patient. If you give a shot every 4 weeks, it's not enough, but it's enough to improve mental health domains, vitality scores, and other. Here are also studies in Iran, for example, men aged 50 years or older, basically more energy levels with testosterone, better quality of life, better ability to exercise. So it does really work. The things I say here are really evidence-based next to experience-based. And then what about vitamin D? Everybody talks about that's a good way to help to stimulate the immune system during this COVID crisis. So you might not get it so easy. And I take personally quite high doses, around the 10,000 units a day. That's very safe. Well, it does increase the whole energy the whole day too. And people who have active fatigue, like adults, patients with fatigue, in this sample of adult patients, 77% had a low vitamin D below the lower limit of the reference, where normally only 2.5% of people are. So basically, if your patient has a low serum vitamin D, you can suspect that part of the fatigue is due to low vitamin D levels. And then when you give vitamin D supplementation, would it work? Yes, of course, it does work. And there are several studies showing that. Here's a study on healthy individuals. You give vitamin D3, a significant decrease in fatigue. There's also in all types of fatigue symptom scores, which can be a poor concentration, a lack of punch, and other associated symptoms. In sick patients, like kidney transplant patients, generally vitamin D does decrease the fatigue scores, but not as much because they're deficient in a lot of other nutrients and hormones. So if you want to get better than a minus 10% fatigue score, which is still significant in this study, you might have to also search for other nutrients that are deficient in hormones. Also in adolescents or young adults with lupus, for example, vitamin D3 significantly decreased the fatigue related to social life scores in these young people. So it does work in all age groups and in all conditions, actually. When, and that's the condition, it generally helps when there's a low level. It doesn't help when the level is already high. That is only the case for vitamin B12. The higher you give vitamin B12, the more energy and the less pain a person can have. Even doses that reach levels up to 1,000 times the limits. Now, coenzyme Q10 can also increase the energy, and that's generally the whole day, but also at exercise. So we have a separate section actually in the lecture in the workshop of the 20th of February. And so here we're looking at the fatigue that is for a person with myocardial infarction. And we know that coenzyme Q10 is very important for the heart. It protects the heart against heart attacks. It lessens heart attacks when you give supplementary doses at that moment. So let's look at the double-blind placebo-controlled study. And 120 milligrams of coenzyme Q10 was given for 1 year, and that gave that there were 6 times less patients who had acute myocardial infarcts that were complaining of fatigue. Imagine, 5 on 6 didn't have fatigue thanks to the coenzyme Q10. That's what this study suggests. And what is the right dose for coenzyme Q10 to work efficiently on the fatigue? Well, studies have been made with 100 milligrams and 50 milligrams, and results were not so good. So basically, you need to go a little bit above 100, and sports activity even up to 300 milligrams to really make a difference with coenzyme Q10 supplementation. And that dose is safe. Carnitin, that's my loved nutrient because it also gives more energy the whole day. And for example, physical activity fatigue scores was decreased by 40% in older adults here that had fatigue. And the mental fatigue decreased by 45%. So that's really interesting and different. And in cancer, many studies have been done in cancer patients, most of the studies even. And in cancer patients, they have more or less 3 hours more of activity with it. Cancer patients treated with chemotherapy, etc. Give it, it's safe, it works. It works by actually carnitin accumulates in the mitochondria and makes that mitochondria can make more ATP. So it's really a very important nutrient. And I take personally up to 6 grams. What it has made is that my physical body in 1 month, it can do that. You have 1 kilo or 2 kilos of fat less and 1 kilo of muscles less, and you lose 1 kilo of weight totally. So basically you're improving at the same time your body composition. And that means a healthier body. Fatigue upon awakening, when you wake up with fatigue, where does it come from? Well, the early morning fatigue actually is generally due to low thyroid. And why? Because the blood flow in the brain is slow when you don't move in the hypothyroidism. You don't have enough blood going into the brain and into the muscles, and then you're tired. And here's a study where they gave L-thyroxine, which is not the best treatment, but it works here. Levothyroxine treatment, so T4 only, significantly improved almost all the scores of the thyroid associated specific disease associated scale, and that includes fatigue. And after 6 months, there was even a better improvement, and also scores were better of other subscales. But there were still some deficits in these scales. The patient was not fully recovered. And I suspect it's because there wasn't additionally T3 given, only T4. And many people are not able to convert the poorly active thyroxine, T4, into the very active T3. So here's a study where desiccated thyroid was given and L-thyroxine alternatively in these patients for 16 weeks, so about 4 months. And when desiccated thyroid was given in the place at the equivalent dose, basically 50%, more or less 50% of the patients preferred that medication compared to only 90% of those who were taking L-thyroxine. And it is compared to when they were taking L-thyroxine, the patients actually had significantly a higher energy level with the desiccated thyroid. And this is not a very old study, 2013. And not only was the energy level better, there was better concentration, better memory, the sleep was even better. There was a better decision-making capability, and actually they were happier. And we as physicians are there not just to make a job like a robot. We're there to make people feel better, really be better, and be happier. So isn't that a beautiful task? And we can also make the patient we ourselves this by getting us the best medication. Always supply the best medication to yourself, because you will be tempted to give that also to your patients. Also, with desiccated thyroid, they lost 4 pounds more than with L-thyroxine. So it really shows that it makes a difference in those 70 primary hypothyroid patients. Now, to improve energy, you need first also to sleep well, to sleep good, or you cannot have a good battery, as is shown here. And there are hormone and nutritional supplements that increase the sleep and improve the sleep. And there will be much more information given in the workshop on the 20th of February. But I must give you this information. If you're taking a sleeping pill, a pharmaceutical drug every day, stop it. Why? Why? Because there are several studies, this is not the only study, showing that the mortality is higher and there's more cancer in those who are taking benzodiazepine or barbiturates or other types of pharmaceutical drugs to sleep. And it's not a little. There's 3.6 to 5.3 times more mortality that was found in people who were regularly taking hypnotics at least 100 days a year or more. But even in people who just take 18 days per year or more, there were other aspects found in other studies, like higher insulin, higher cholesterol, and things like that. So basically, don't believe that these are completely harmless. They make you sleep better, but kill you quicker in certain sense. And it's not just one study. You can look up the literature. Also, in the there were on the average 35% more cancer found in patients using regularly hypnotics. And it may be not that the hypnotic is a problem, but that well, it is the problem because it's more cancer and people are not taking, but people who take hypnotics are probably also people who are not sleeping well. And when you don't sleep well, you generally have low melatonin and maybe even low growth hormone. And these hormones can have a protective effect against cancer. Yes, growth hormone, not only melatonin. There are studies showing that in growth hormone therapy given to adults, they develop less cancer. Now, also hormone therapy to fall asleep quickly if you want to sleep good and remain asleep the first 4 hours of the night. That is generally typical for melatonin, that's the melatonin effect. So when there's not enough melatonin, what happens? What type of sleep is there? Well, there's a great difficulty to fall quickly asleep within 20 minutes when you're in bed. If you have that, you're probably low in melatonin. And then there's a tendency to be in the night anxious thoughts, to have worries at night. And melatonin deficient companies, there's also tense body at night and tense muscles. It's really also has a muscular effect, melatonin, if there's deficient, it's tenderness. And if you give melatonin, it's a very good muscular relaxant substance. So how does melatonin work? It works, and in the seminar, we'll see many of those mechanisms of how a hormone or a nutrient improves sleep or energy. And here, let's look for melatonin. Melatonin has the capacity to decrease the levels of excitatory neurotransmitter. So it decreases noradrenaline and adrenaline. It decreases in the body the glutamate action in the brain. It counters that action. And it also decreases dopamine excitatory activity action. So basically, that's how a baby can make, after the first 3 months, it makes a lot of melatonin. That's how you see this very relaxed effect of melatonin that comes down those excitatory neurotransmitter. But it does more. It stimulates the levels of calming inhibitory neurotransmitters. So you have more serotonin levels in the brain, a better parasympathetic activity. Also, that's the parasympathetic nervous system, the one that calms you down. And they also, it improves the number of benzodiazepine receptors. So if you combine melatonin and benzodiazepine, the benzodiazepine works better. You need a lower dose, a safer dose. And so the hormone therapy to fall asleep earlier when you have a jet lag or you have delayed sleep phase syndrome is also actually melatonin. It corrects this delayed sleep phase syndrome. In this sample of 8 patients with delayed sleep phase syndrome, 5 milligrams, you need to give higher dose in this case, at least in the beginning for 4 weeks. 5 milligrams compared to placebo provided a 1 hour 22 earlier sleep onset time. So they fell asleep 1 hour and a half, more or less, earlier. And they were about 2 hours less awoken during the night. So they didn't wake up as easy, they slept more. And in total sleep time, it was less because it was a better quality of sleep. So you need less, more than half an hour less. So it really helps. This is the #1 treatment to treat delayed sleep phase syndrome. Now, of course, I will also stress that when I provide information on a hormone and a nutrient, that you need also to be careful not to overdose the hormones. And the overdose can be taught to patients because they can observe it. They are generally psychological, physical complaints. For melatonin, for example, a heavy head in the morning when they wake up with a heavy head, or intense dreams at night. So the intense dreams at night are very, and that's the major complaint, very intense 3 to 4 hours of sleep. So you sleep deeply the 3-4 hours because you have too much melatonin, but then it stimulates the thyroid function by stimulating the conversion of T4 to T3. So you get more thyroid, and then you wake up sweating, warm, and heartbeats in hypothyroidism, T3 hypothyroidism. So it's, and then you stay widely awakened for 2 or 3 hours before you can fall asleep again. And then in the morning, you get this heavy head in the morning. So basically, it's very, very easy to recognize when there's an overdose, and most patients are overdosed. If you take more than 0.5 milligram orally or more than 0.1 milligram sublingually, generally you're overdosed. All these practical tips we'll give even during the workshop. So let's look at some nutritional therapies that can help to fall asleep quicker and remain asleep the first 4 hours of the night. Now we see that these nutrients, to do that, they convert to melatonin 4 hours later. So that means if you give tryptophan and 5-HTP, tryptophan becomes 5-HTP, 5-hydroxytryptophan, and that becomes serotonin. And then serotonin becomes melatonin after intermediate steps. If you give that just before bedtime, they will make you sleep longer the last 4 hours of the sleep. But if you give them 4 hours before bedtime, 3 to 4 hours, they will convert into melatonin, and they will make a patient fall asleep easier when he goes to bed or she goes to bed. So you see the doses that of tryptophan that are generally already efficient are 300 milligrams, or I start at 150 milligrams and then increase. And the dose of 5-HTP on generally 25 to 50 milligrams is enough to start. If more is necessary, you can give more. And so this is taken 4 hours before bedtime to make a patient sleep earlier. But if you need to sleep the 4 last hours, it's just before bedtime you give these substances. So the hormone therapy to sleep deeply, and that is actually growth hormone therapy. And growth hormone therapy really improves the sleep. You see, for example, that growth hormone decreases total sleep by 40 minutes. You would say that's not good, but it decreases the superficial sleep by an equivalent number of time, and that's not very useful. And it increases the growth hormone and it decreases the deep sleep and the REM sleep and the rapid eye movement phase sleep with the deep sleep are the most important sleep periods and sleep phases where we will recover and also memorize information. So basically, this shows that growth hormone deepens the sleep, more deep sleep, less superficial sleep. And nutritional therapy to sleep peacefully and relax the whole night. If you're tense, you go to bed, you have worries, etc., there's one good nutritional therapy. There may be several, but this one really is efficient. And that's GABA, gamma aminobutyric acid. It's an amino acid. It's the number one neurotransmitter to calm down anxiety and pain, but it also makes you sleep because it makes you so fully relaxed. And so the GABA, when there's GABA deficit, there's an intense anxious sleep. You're very anxious. Without GABA, anxiety. And we'll talk about what the doses are and things like that. But just remember that this helps, but you may have to be careful. When you give GABA treatment, some people can get suddenly sad because it's too much for them. They need lower doses, or they need to take it just 1 or 2 nights and then stop for a certain while. There's also hormone therapy that makes you breathe better at night and not snore. And the number one therapy for that is actually thyroid hormones, giving thyroid therapy takes out the myxedema in the respiratory system, and the people sleep better. They have no sleep apnea or less sleep apnea. So when you see this person looks a little puffy in the face and seems to have a big, large tongue. Suspect that there is here a lack of thyroid hormones, hypothyroidism, and that by treating hypothyroidism, you improve. And how much would you improve? Well, look here. If you give thyroxine to those who had sleep apnea and who had also profound hypothyroidism, 92% decrease in apneic episodes. So it's really more than 92%. It's really, really very, very important improvement. And so the snoring was much less in these patients. So we saw about energy, about sleep. Let's look at some of the slides that we'll see in the workshop. And there's a presentation on how to improve the immune system and decrease inflammation by a healthy diet. And that's actually the first step we should do as a physician. We not start by giving anti-inflammatory substance, by giving antibiotic, but first, healthy diet. I even say to my patients, it's no use to take my treatment if your food is not good enough, because you will lose a lot of the efficacy of the treatment by supplementing the wrong foods. So let's look at some of the drinks and foods that reduce inflammation and improve immunity. Water, for example. Water is anti-inflammatory. Simple substance. You think it's not scientific? Well, let's look at some of the references. So water drink is a major anti-inflammatory therapy. They know this very well in a lot of thermal centers and thalassotherapy centers also. So you have, for example, healthy water is anti-inflammatory, purified water, mineral water, it's anti-inflammatory effects, thermal water, river water, hydrogen water, that's reduced inflammation. You put magnesium in water and it becomes hydrogenated, and that's very healthy. Reduce inflammation, deuterium depleted water, ionized water, ozonated water, full fruit derived water. So all types of different types of water, but it is anti-inflammatory. And adverse impact of water deprivation, etc. So basically, first thing we do, make the patient drink water and eat the right foods. Among the right foods are fruit and vegetables, and they stimulate the immune system. For example, how much do you think is necessary, fruit and vegetables? Well, to reduce the risk of infection, you had less than 4 servings per day, or more than 8 servings per day. Well, when actually 8 servings or more per day, decreased by 26 to 39% upper respiratory tract infections in pregnant women. So that's already a major effect. So you get less, I would say, tracheitis, less sore throats, less colds when you eat a lot of fruit and vegetables, 8 servings per day or more. Also, enough protein-rich foods must be eaten to have a good immune system, and actually, especially for good mucosa. This is in a controlled diet in animals. And you saw that here, protein, this looks a very beautiful intestinal mucosa, but you see that there are already abnormalities in part. There's shorter villi, and there's intact epithelium and fluid accumulation in the lymphatics here. So it's edema here, with a protein deficient diet for 7 days. So it's already the first barrier against infection is altered. If you have a protein deficient diet in these rats for 14 days, you have a further shortening of the villi. And so they get shorter, there's less number of defense cells. Normally there's a lot here, and there's less here, the lamina propria here. And when it becomes 21 days, you clearly have atrophic villi and crypts. And you may still have an intact epithelium barrier, but the defense is much less against infections. And so what happens to these mice here that had a low protein diet, they had a much lower survival from pneumonia, when they were on a 2% protein deficient diet. Actually, after 11 days, all died while there was almost none. Only 10% died. Was a 20% rich diet. Makes a big difference. So don't take enough proteins. They provide the amino acids, which are the building blocks for your immune system and for your body. This is how a protein deficient mouse looks like compared to one that is healthier with a protein rich diet. And we note that the pneumonia that killed those mice actually was a pneumonia due to the Sendai virus. And this is a pneumonia that is a viral pneumonia that is in many infants in developing countries. So we've seen how important it is. The diet, there's much more information to give, but I'm trying to give you things that you can remember and include into your practice already now. And more will be given in the workshop. And how to improve the immune system potently with hormone therapies. Because you really can drastically improve the immune system. You may get, if the treatment is good, no flu anymore, for example, much less coronavirus. My daughter, for example, did not respect the confinement at certain moment, and she was with friends in a small party, but they were very close to one another. One had the COVID, nobody knew that, and he infected everybody. And she talked with that boy actually, who during half an hour, very close by, no problem, didn't get the infection. No antibodies, no infection. Her mucosa was probably good, and she probably has a good doctor. I suppose so, because I was her doctor. But basically, it shows that the immune system was remarkably well with nutrients and hormone therapies that she's on. So then there's a very good topic about what the role of hormone therapies in immunocompetence. And that's based, I did 7 months, day and night, weekend included. I worked on all the therapies that improve the immune system, all the hormone and nutritional therapies that improve the immune system, and the dietary therapies. So it took me a lot of work, and I reviewed all the literature of the last 40 years. And plus my experience, so I made a lot of good lectures. I have models of learning that. But basically, what I want to give you is a short little overview, or better, some aspects of what I'm talking in that, and that I will talk about a 2-hour lecture in the workshop on 20th February. So you get a lot of the major things. So thyroid therapy is really a therapy that stimulates the whole immune system. And the thyroid secretes several T4, T2, T2, T1, T0. And thyroid therapy, for example, to give you an example, how it increased their immunity, it can increase the weight of the thymus, the size and cell numbers of the thymus. So we really have a better thymus. And you know, and we'll see that probably in the next slide, at even higher above average doses given of thyroxine have even better effects than lower doses. Lymphocyte numbers and their reactivity are improved. So, you know, the lymphocytes are cells that defend us against virus infections. That's improved. The T lymphocyte activity is improved. The CD4 T lymphocytes are also improved in number. And there's also a greater number of CD8 T lymphocytes, which include also cytotoxic lymphocytes that can attack pathogenic invaders. And also the CD4 and CD8 cells in lymphoid organs are improved. It actually redistributes. When you have thyroid hormone, the lymphocytes get out of the thymus and go where the action is in the lymphoid organs. And the ratio that's so important for the immune system, the CD4 and CD8 ratio, is also improved, meaning that the immune is boosted. And the production of a protective hormone by the time thymidine is increased, and Treg cells that calm down autoimmunity are actually decreased. So because you need, if they're too much present, they may counter the action, immune stimulating action of the thyroid hormone. So it really helps to have a better immune system to do that. And then there's also more antibody production, especially EGA production is improved by thyroid hormones, and EGM production. So those antibodies that can quickly have an action and are necessary are better secreted. So there's an increase of the B lymphocyte activity. And so here to show you in rodents, studies have showed that the effect on the size of the thymus is that at low doses of thyroid hormone, the thymus enlarges. It becomes hypertrophic. At higher and slightly excessive dose, there's even a slight hypertrophy, so a little bit less. And at excessive dose, it shrinks. So it shows that actually thyroid hormones at low dose or slightly excessive dose do give a certain hypertrophy of the thymus. And here's a study that shows the redistribution to the lymphoid organs with thyroid hormones. So these is the subjects were mice here, and they injected into the thymus triiodothyronine, T3, the most active thyroid hormone. And what we see here is that the thymocytes, the lymphocytes in the thymus went from the thymus to the subcutaneous and mesenteric lymph nodes with this T3 put in the thymus, and that there was a decreased numbers of CD4 cells in the spleen. CD4 cells are T lymphocytes. And so basically there's a whole distribution that what you see here, for example, and here is subcutaneous nodes had more lymphocytes, mesenteric lymph nodes more, and spleen not more or less. So there's a redistribution to where the action really has. Here's another study showing that T3 treatment increased the natural killer cell activity in older adults. And how does it do it? Well, older adults with serum T3 within the reference but low normal had improvement, more natural killer cell activity. And older adults with a serum T3 in the middle of the reference range, which is the optimal value for T3, no effect, doesn't increase natural killer cell activity because they already had enough T3, an additional amount would not help anyway. And healthy young adults that are also often at the mid-range, no effect. So you actually, and this is a secret for hormones, is that hormones work to improve the immune system when they correct a deficiency. And low normal values are already a deficiency. But if the levels of thyroid hormones are good in blood or in the tissues, it doesn't work really because it's not really necessary. And so in practice, what we see is that thyroid hormones are important against infections. And we know actually by a number of studies that show that low levels of thyroid hormone are associated with more infections. Like for example, for colds, for nasal obstruction, there's much more in hypothyroidism, and we give a thyroid treatment. With the thyroid treatment, you significantly decrease the complaints. There's a disappearance of the complaints. And the thyroid on the coronavirus, what is the relationship? Well, in patients hospitalized for COVID-19, they have low serum TSH level and low T3 levels. And so you see this here, the significantly lower levels are in them. Actually, 56% have low TSH levels because actually probably the infection affects the whole endocrine system and it works less. But also when patients who have a low endocrine system will have easier infection. Must be a sort of association between the two. And the lower the TSH level and the T3 levels are, the more severe the COVID-19 infection is in general. And after recovery, everything seems to normalize, seems not to be a relationship. But so basically, it's better to have high enough levels of not only T3, but also TSH. And because of these reasons, anecdotal studies have been done where they gave in a puff T3 to a patient with COVID-19 who was so severely affected that they lost all hope of saving the patient. There were 2 patients like that. And there was a sort of dramatic recovery of those 2 patients thanks to those puffs of T3 that they received, so that they're now doing a study to show if this can be a useful tool for other COVID-19 patients. Also, thyroid hormone, they can there can be a relationship with herpes zoster. Is that what is seen is that hypothyroid patients who tend to have herpes zoster, if they get a thyroid supplementation, they actually have a 40% lower risk of herpes zoster. And that's significant in all age groups that were examined here. And it's even more efficient in hypothyroid women than hypothyroid men. So the take-home messages, and there are many take-home messages in my lectures because they will really make a difference for your patient if you apply that, is that treat with thyroid therapy any degree of hypothyroidism you find in a patient with recurrent herpes that will decrease the herpes zoster recurrence. There's another hormone that is even more efficient, where you really get a more than 90% decrease in herpes infection, and that is thymosin alpha-1. But I won't talk about it now because it's not so much available in the United States, but basically there are some good tools next to the thyroid therapy. Thyroid therapy also good against Helicobacter pylori infection. You know, that gives those stomach ulcers. That's how Helicobacter pylori looks like. And there's a study that shows you that 3 months of thyroxine therapy in patients with hypothyroidism and Helicobacter pylori infection, there was a total disappearance of Helicobacter pylori infection in these patients. So, because the immune system is so boosted by these strong hormones, the strong thyroid therapy. Then cortisol is the crucial immune enhancer. And we always think that cortisol depresses the immune system, but that's by overdosing, not by the right dose. And it's so important because some people don't recover from COVID-19, and also not from the vaccine. Some people take the vaccine now and not so good. We have more than 200 deaths of people having taken the vaccine in Belgium, and just after 1 month of supplying in our country the vaccine. So and they say it's not because of the vaccine, but anyway, I think it's because the vaccine caused adrenal deficiency, and then they get this problem. But some don't die from these COVID-19, but after they're like destroyed. Their life looks like over because the COVID-19 continues on. This is one of the patients that was in the BBC reported 6 weeks after start infection, still sick and helpless. That's adrenal deficiency. You see also the signs of adrenal deficiency, the dark circles under the eyes here. You'll see the irregular pigmentation that she seems to have here, and pigment spots. She has Addison's disease. So cortisol is produced by the adrenal glands that are here. And without the adrenal glands, we cannot live. So if we have weak adrenal glands, we must suffer from something. And among those things, in Addison's disease, for example, where there's a decrease in natural killer cell numbers. You see natural killer cell numbers of various species are lower in these patients. And there's not only less natural killer cells, but on the surface of cells, the natural killer cell activating receptors on natural killer cells, their surface, there's less receptors. So that they are less active, the killer cells that remain in these patients. So that gives a sort of double weakness to the immune system of these patients. And you see endogenous cortisol is actually important because the higher it is, the higher there's natural killer cell activity. So when you supply ACTH that increase the serum cortisol levels, you have an increase of natural killer cell activity. No effect on the number, but they are more active because probably they have more receptors on their surface to respond to stimuli. If you give oral synthetic glucocorticoids even at high doses, you decrease ACTH and cortisol secretion, and you can get a natural killer cell activity decrease. But that's not on physiological dose of cortisol, but on pharmacological dose. So I'll show a lot the difference between the two in the workshop. And so you see that physiological dose of hydrocortisone on the immune system can increase the neutrophils. So they don't decrease the neutrophils, they increase the neutrophils, even at high doses. They increase the activity of the neutrophils. Neutrophils are important for our resistance against bacteria. They decrease allergy and eosinophils. They increase the macrophage number and activity. So if they increase the activity, they're more potent, these macrophages. Dendritic cells are increased. Those are also macrophages. And the CD19 cells, which are the B lymphocytes that make antibodies, are increased at physiological doses of hydrocortisone. And there's more antibody production. There's more CD3 T lymphocytes, and there's more CD4 T lymphocytes, and Treg cells are more. And the CD8 T lymphocytes are more, and there's a decrease in natural killer cell cytotoxicity, those effect that is less interesting for the immune system. But most of the other effects are important, but I repeat, at physiological doses. So what to do in case you have a flu of our acute infections, and I will talk about this strategy in Profound. I'll give you little tips now, is that there are two different strategies to provide cortisol or hydrocortisone or a synthetic derivative. Either you are very quick and you're in the first 6 hours, then you only have to increase the dose of or add cortisol just for 1 day and it will be over, and maybe just a few hours. If the infection is already there since 1 or 2 days, it's another strategy. And so here what I'm showing is that if the patient is quick and takes supplementary cortisol in the first minute or 6 hours of the flu is usually over within 2 to 4 hours. Unbelievable, but it's true. And it works over and over. I have adrenal deficiency. I correct my cortisol. If I have the impression I'm getting the flu and I have some signs like sore throat, I take additional doses every half hour, and in 2 hours, it's gone. I am cured. Of course, I tend also to take DHEA at the same time. So there's always a good balance between my catabolic and anabolic hormones. DHEA, what can it do? There's a lot that can be done. I won't go over, but I'll tell you one thing is that this helps when you give it with cortisol. When you give cortisol, you always need this substance, or you may have not so good effects on the immune system. So DHEA on itself has a good, it's good stimulator of the immune system. It's even it can inhibit the AIDS virus, for example, to show one of its effects that is impressive. And then what about melatonin? This is a substance that is in every being in the world, every living, a plant, an insect, a bacterium. You find melatonin. Every living being that has been examined for melatonin has been shown to have melatonin. So we estimate that it's more than 3 billion year old immune protector. And if it's in so much living beings, it has to have a protective effect against dying, but also a stimulating effect on the immune system. When you give 2 milligrams of melatonin to young adults, for example, you double the number of natural killer cells. Natural killer cells are the cells that actually stimulate, that actually protect you against not only viruses, but also cancer cells. So melatonin on Helicobacter pylori infection, to show one, these were patients that were treated with an antacid because they had ulcers. And the placebo group, after 3 weeks of placebo, there was about 43% of gastric ulcers and 43% of duodenal ulcers that were cured. But the group that received melatonin with the antacid actually had, and it was 2 times 5 milligrams per day of melatonin, had a cure of all gastric and duodenal ulcers. So it more than doubled the healing rate compared to those who were not treated. This is a duodenal ulcer. This is a gastric ulcer. And the group that received tryptophan had also a cure of all gastric and duodenal ulcers, and tryptophan, by converting to 5-HTP and then to serotonin and then to melatonin, makes melatonin. So they both had significantly increased the serum melatonin levels. Sepsis also, these are children, septic newborns that were 10 of the 30 received, well, there were 20 septic newborns, 20 received melatonin, 10 not, and they were compared to 10 healthy newborns. And what we could see is that 2 times 10 milligrams per day, which is a high dose, but not dangerous, when they received this oral melatonin, it actually significantly decreased lipid peroxidation products. So damage to membranes of cells was much decreased, and it saved the life of all those 10 septic newborns, while in the group that actually did not receive, that had sepsis and did not receive melatonin, 3 on 10 died. So basically, very good treatment to help survive a newborn that has sepsis. Estradiol infection, this is this very important study on HIV where it shows that if you give to monkeys, you inoculate in the vagina HIV, but you have given to those monkeys that were castrated before, female monkeys, they could not develop the HIV infection. While those who were castrated but did not receive estrogen actually got HIV very easily. So it helps to protect by giving a thicker vaginal wall that prevents HIV to penetrate. Estradiol is also known to decrease bladder infections. So we'll show data and give some information if it has to be systemic or it can be only local enough that is informed. What about testosterone infection? Testosterone on COVID-19. You see here that these were men that had the COVID-19 pneumonia. And this is a COVID-19 pneumonia here, for example. And you see all this white stuff here. Because of the pneumonia, developed an acute respiratory distress syndrome. And actually, those who developed this severe acute respiratory distress syndrome had much lower levels, 70% lower than those who did not develop with the same infection, acute respiratory distress, and there's 65% decrease of serum, the free testosterone. And to show a bit the difference is that, for example, the risk of being transferred to the intensive care unit, so to have severe form of COVID-19, was 23 times higher, there were 14%, if the total testosterone in the man was below or at 1,450 picograms per ml or 5 nanomoles per liter. But that's a low level. That's a level that is actually in the 1% lowest values of young adults. So it's a low level. The good level would be 7,000 and not 1,450 picograms per ml, 6,500. So you really have a level that is 3 to 4 times lower than normal. But that level is very, very dangerous. And you have 31 times more mortality at that level of total testosterone. And that's what these data say. I won't go into details here because of time, and it's time also to have questions, and we're a bit at the end of the lecture. Here, the testosterone also shows that when you give to patients who had very severe fibrosis of the liver, and actually they had a liver transplant, they had to have that because they had severe viral hepatitis C. But the liver transplant also started to fibrose, and the decision was given to 5 of the patients not to give any other treatment. All these patients died within less than 3 months after the liver transplant. But those that received testosterone gel 1%, which is not a high dose, for 6 months, significantly improvement in all the parameters, albumin, muscle strength, well-being, etc., and none of them died. Simple treatment, great consequences. There will also be patient cases discussed during the workshop, But we're going also to propose, because it's an online workshop, we're going to propose to participants, if they want, and if you want, please register and give your name that you're ready for that. We can do a little consultation in place of just anonymous patients that I would take off my data bank. We could do a clinical examination, a little interview. So you have a short consultation of 15 minutes or maybe 20 minutes of people out of the audience. And you will see that it works very well through internet, because I do a lot of consultations now, and you can really have a good idea just by examining the patient and having some basic information on the complaints to how to solve the case then. So we have good diagnosis and good an idea of the treatment. Of course, with or without lab tests, better with lab tests to have an idea. But these are really exciting, and the reaction we have physicians is very good. So upcoming A4M workshop is on February 20th. And I'm really happy to do it. Very grateful for the A4M to participate. And this is the flyer, actually. You have a special deduction if you register now. And I can tell you it's really exciting, because we're all here to make our practice better. And here are the different topics: the role of hormone and nutritional therapies in immunocompetence, foods that reduce inflammation and modulate immunity, the hormone nutritional therapies for better sleep. And then we'll have patient cases examined for health and immunocompetence. We have also the honor of having Professor Sarah Sweden, who will give us an update on what you can and cannot do, or have to be careful to do in bioidentical hormone replacement and growth hormone. So I'm very grateful for her that she talks, because she's, I'd say, more knowledgeable than me about the local regulations in the United States. And then we'll have again some patient cases, but I hope to have them clinically, because you'll see how alive. And if you have lab tests and you have things like that, and it can make a short resume of your case or a patient case, but it's good to see the person also. We can analyze that in the place of the case that we'll present. Then we'll have a closed session then. And what about the books? Well, if you really want to make your training and your practice good, there are two books that really make the difference. And books that I've written a practical guideline, the Hormone Handbook, that I sold a lot of copies of this. There's very extensive information on how to do it, but very easy to understand, so you don't lose time. And so the Hormone Handbook is the #1 book to buy to really be able to practice these therapy. And the Atlas of Endocrinology for Hormone Therapy is the #2 book for this workshop, especially because you see all the clinical signs of hormone deficiencies and excess. And you can order them on the website, hertogmedicalschool.eu. And you get, if you buy the two, there's 20% less for attendees of the workshop. And then the latest book is that I wrote, which is, I think, the most, or one of the most complete book on testosterone. We have everything on giving testosterone to prostate cancer patients, reducing prostate hypertrophy, how to treat too much female hormones in men, and so many other things, how to improve sexuality in men with testosterone and some other therapies. So you really have very extensive, with enormous literature, but it doesn't, it's really oriented to practice, so that you have a special 20% reduction on the book for attendees of the workshop only. And so you can register on the A4M website, and I think you will receive by email or from the organization. If you want more info from one of my assistants, there's office@hertog.eu. And so I thank you for your attention. And now it's time for questions. And I think, Lindsay, that you're going to select the questions and ask the questions to me.
Yes, thank you so much, Dr. Hertog. I will be sending out a registration link for everyone who would like to attend with the special rate. Many of you are asking about the recording. We will be providing the recording within the next 24 hours to our attendees. So we will include all of the registration details in that email. So please keep an eye open in your inbox, and we'll get started with questions. Dr. Hertog, besides bone health and breast cancer protection, what are the other benefits of raloxifene?
Raloxifene, I don't really work with it, so I'm not the most competent to give a good answer, because usually with the treatments I give, I don't seem to need this. And normally it's a bit considered as having less cancer promoting effects than female hormones, and a safer way to do. But I think once you are able to balance well the female hormones, have a whole model on how to balance the female hormones, you're doing it even safer. There's a number of studies showing that when you give female hormones to women who have breast cancer, that actually who had breast cancer, then they receive female hormones, you decrease the recurrence by 50 to 70%, and the mortality between 20% less to 80% less. So basically, I cannot give the best answer. I think it's a treatment option to take when, for one reason or another, it's decided not to give female hormones to women, and that it's a valuable alternative, but not as efficient and not as so, I would say, promoting energy and happiness than female hormones can do.
Is there a worry about giving testosterone to breast cancer patients since it can convert to estrogen?
It can thus, if in some women, it can convert more quickly to estrogens and too much to estrogens. And those women are women who are very poor in male characteristics and very rich in female characteristics. So very big breast, for example, a very big pelvis, almost no body hair growth. They will convert much quicker the testosterone into estrogens. But in most studies, testosterone shows to be an excellent substance to protect against breast cancer. They even give it to breast cancer patients, and they even put it locally around the breast cancer tumor, and it shrinks the breast cancer tumor. So basically, there's always ways where you can decrease an excess conversion of testosterone to estradiol, and so I think it's better to provide testosterone, but to do it safely and control that it doesn't convert excessively in estrogens. And a woman can know that if it converts too much, she gets breast pain with the testosterone. My wife is like this. If she gets too much testosterone, she converts to estrogens, and she has to stop her estrogen treatment during several days, and stop also the male hormones till that comes down. So we're actually balancing it better now with more progesterone. But there's a case. Generally, you have to think that it's safe to provide to women, and that is rather protective.
Any thoughts on why my patient didn't tolerate CoQ10? She was dizzy, lightheaded, and felt faint.
It's very hard to believe that coenzyme Q10 would have caused that directly. So I suppose that coenzyme Q10 was with fillers in the capsule, in the oil capsule, and that was not on. Maybe there was peanut oil mixed to the CoQ10 if it was one that was put in oil, because you have also powder. And so I think it's more an additive that was with the coenzyme 10 that have caused that. Because otherwise the coenzyme Q10 is rather almost non-toxic. You can give enormous high doses. We give to some patients with Parkinson because that's protective effect, up to 1,500 milligrams without any problem. So I think it was probably bad quality additives that were added to it, or the oil that was perished. It was an oil solution.
Can melatonin be given with oral progesterone, and can it be given as a long-term treatment?
Melatonin is generally given separate than progesterone, and it is given before bedtime because it's sleep inducing. And progesterone, the natural progesterone, the micronized progesterone 2, is given before bedtime because it has sleep inducing effect. The sleep inducing effects are not the same. So you generally, if to have a good sleep, a woman makes progesterone and the melatonin, she needs to take both together. So you can certainly give both together, but maybe lower doses of melatonin necessary when progesterone is given. To have the sleep-inducing effect of progesterone, it's better to give it orally than vaginally. The absorption is better vaginally, but orally it will then be absorbed, go in the liver, and the liver will convert it to two metabolites that stimulate sleep. In patients that calm down anxiety, allopregnanolone and pregnenolone. So those two are more made orally. So if the sleep is to improve, the sleep improvement is the focus, give them orally. progesterone.
What tricks do you,
Yeah,
my apologies, sorry.
no, go on.
What what tricks do you have to increase vitamin D levels in a patient with VDR receptor genetic SNP, as they do not seem to increase even with 10 to 20,000 of vitamin D3 per day?
Well, you can inject the vitamin D, and then you're sure it's in the body. And so that's better, injecting. And then you have to also to know that some patients are not eating enough fat. And we know that fat-soluble vitamins are better absorbed when they're taken together with fatty foods, because it secretes, it stimulates the bile, and then there's a better absorption. So many of those patients have also an additional thing they do is they are on a low-fat diet, and that will make that even if they go in the sun, they're not able to make not enough vitamin D because they don't get the precursors enough. So I would really think that they need to increase the fat in their food and take out of the food what might make you lose fat in the stools. And that is whole grain bread and all cereal fiber, grain fiber. So you really need to improve the food in these patients and possibly inject the vitamin D intramuscular.
Could you please repeat your preferred oral dose of melatonin?
I have no preferred dose of oral melatonin except in some disease situations like severe cancer and things like that, because it works much better sublingual. So sublingual melatonin at lower doses is more efficient. Within 10 minutes, it's absorbed. And it has an effect, and then you fall asleep. If you have shut out the lights, you fall asleep. If you take an oral, it takes half an hour before it's absorbed, and it goes to the intestines and it has ups and downs. So the average dose of sublingual melatonin is 0.1 milligram. It can be lower, 0.05 milligram or 0.2 milligrams. That's a usual dose if we don't count jet lag, because then you need to take more. If you prefer anyway, orally, it's between 0.5 and 3 milligrams that may help. But it won't have the same efficacy, the same stability and efficacy as a sublingual melatonin.
Do you give thyroid hormones just based on symptoms, even if the labs are normal?
I never have normal labs, but the way I interpret the labs is different. I base my interpretation on studies. Many studies have shown, and I showed this also in my hormone handbook. You have a whole overview of many of those studies. And we have the International Hormone Society website where you have even more studies, and that's free accessible, where you have the study that showed that within the reference range, there is pathology. Showing that, for example, if you have a TSH, the reference range is between 0.4 and 4.5. If you have a level that is above the TSH of 1.3 or below 0.4, you have more pathology. And so I tried to get an optimal TSH and an optimal T3. So if the TSH is at 2, there's high cholesterol often. If it's 2.5, there's more depression, there's more cardiovascular disease. And so you need to put in an optimal range within the reference range your level. So I almost never have lab tests that I can say are not pathological, but they're within reference range, and I will treat the patient if the patient has a lot of complaints. I also do 24-hour urine, and you have labs within the United States, 2 or 3 labs that do the urine, the 24-hour urine test for thyroid hormones. You have a 24-hour picture, and they usually show up much lower than the blood. Blood is fluctuating. Well, that's more stable test. So I do, of course, a lot of physical exam, a lot of, I collect all the combinations they have that are suggestive for hypothyroidism, but I also have lab tests that confirm. And in order to, I have a whole model that that explains that in 8 to 10 hours of lectures on thyroid hormones. That's fascinating because it's not losing your time, because then you really know how to do it, and you will see that your patients will be happier of the results of what you're doing. So, yes. Next question.
Will the workshop discuss optimal lab values?
Yes, always. It doesn't have to focus on that, and you can always ask the questions. But we have patient cases where I show the lab test and interpretation. So it's, I would say, almost any lecture I give has some information on optimizing the values.
What dose of cortisol plus DHEA do you recommend to kill the flu before it progresses?
Well, there are two doses. Okay, imagine you're a person who's occasionally cortisol deficient when you have the flu. Otherwise, you have no symptoms. You could eventually just take a treatment just once. And that's a colleague of mine who developed that dose, or one of my students actually who thought a little bit further. And he takes, he's a man, he takes 30 milligrams. For a woman, it would be average 20 milligrams. He just takes, he gets sore throat within the first 6 hours. As quickly as he can, as he spots it, he takes just a dose of cortisol, 30 milligrams, and it's over. If you do that, always take a little DHA. If the patient is already on cortisol, and it just every half hour, an additional dose of 5 milligrams of hydrocortisone, if it's not too severe, the disease, if it's severe, it's 10 milligrams during every half hour during 2 hours or 2 hours and a half. And that's enough. If you're very quick, it goes over. So basically, it is possible that you take, if you're already on 20 milligrams or 30 milligrams, that you take double dose during that time, but the flu will be over if you're quick. If you're not quick, you wait 2 days before increasing the dose and you have adrenal deficiency, then you just take 50% more of the dose during 5 days, and then it goes slower away. But it won't work by taking every half hour during 2 hours to get rid of the flu. You have waited too long. You have to take a higher dose of 50% more during 5 days, for example.
Is there evidence of thyroid therapy for osteoporosis?
There's evidence that actually thyroid therapy in menopausal women who are not treated with female hormones, that thyroid therapy then gives osteoporosis or more osteopenia. So there's no evidence in other cases. So you have to have a second hormone deficiency for thyroid hormones to cause osteoporosis or osteopenia. And the best thing is then always to treat all the major deficiencies: the anabolic hormone deficiency, that's the female hormones, and the thyroid hormones, which are a little anabolic, but also catabolic. So you need to be careful with thyroid hormones given to women who don't take female hormones and need it.
Is melatonin contraindicated in sleep apnea or during sleep disturbances with COVID-19?
I don't think it's contraindicated because melatonin is extremely anti-inflammatory. Melatonin can also stimulate the conversion of T4 to T3, and thyroid hormones are very protective against sleep apnea. So basically, I think melatonin can be given at high enough doses, but ideal is to treat all the hormone deficiencies. There's many studies now getting out. They say that melatonin could be a savior in COVID-19, but I didn't see a study where it really was applied and saw the results. So I can still not give 100% enough information. And I would personally, as long as I don't have information, wouldn't give the very high dose that are sometimes recommended of 20 milligrams. But you saw that in sepsis, for example, in children, they give them 2 times 10 milligrams of melatonin orally, and it worked wonder. It saved their life. So I think it's very safe in COVID-19. But for sleep apnea, it's true that I thought I read a level that levels could be a little higher. Sleep apnea, it won't harm, but it probably won't do much big difference. You really need to treat the thyroid deficiency that these patients have, and that causes the snoring because of mixed edema.
How do you treat women who are perimenopausal and have highly fluctuating estradiol levels?
That's very easy to make the menstrual cycles much more regular. And I just gave 2 days ago a webinar on that, and I have a whole model on that. Is that if the menstrual cycle is irregular, there's always an estrogen deficiency. So if it's a woman who still has cycles, you give it from the 5th to 25th day of the menstrual cycle. You give estradiol, the same dose. And then you give from the 15th to 25th day on the average, a small dose of progesterone, like 100 milligrams from 15th to 25th, not more, because it's mainly an estrogen deficiency, irregular cycles. And then the menstruation will follow 2 days after stopping together on the 25th day of the menstrual cycle, the estradiol and transdermal estradiol and the oral progesterone, vaginal progesterone. By stopping 2 days later, they get menstruated. So you regularize the cycle. If not, if it's still regular, you have short cycles or long cycle, it means that you still don't have enough estradiol in most cases.
What is the injection dose and form of vitamin D3? And must K2 be given along with the D3 in the same preparation?
So what is the second part of your question? Because the first part I'll just answer is that what we have here is not vitamin D3, it's vitamin D2 injectable. It's called Sterogel, comes from France, and you can inject that oily solution. So I don't know if in the States they have some similar solution. I suppose that you do. And you just inject it intramuscular. And it's called Sterogel, like stereo and GYL. Now, what was the second part of the question?
If K2 needs to be added to the same preparation.
It's always good to add K2. I don't prescribe it so much because I don't treat so much osteoporosis, or I should have a bit my mind more focused. So I'm not always familiar with the right dose to give of K2, but I think it's certainly very good and it's safe as long as you don't go on a high dose of, you never give 100 milligrams. I think it's 10 or 5 milligrams you could give of K2, but not more.
How would you recommend melatonin to a shift worker, those that work night shifts and day shifts?
Melatonin has always been taken before you go to sleep. So if you change your rhythm, always before sleep, not 3 or 4 hours before you go to sleep. And if you have a more important shift, you just are changing your shift, the dose you take for the first day of that shift, and maybe the next days also, the next 3 days at least, you take a higher dose. And that dose can be 2 to 5 times higher. It depends on how intense this shift is, the shift changes. So let's say if you take, for example, sublingual melatonin 0.1 milligram, well, you might have to take 0.5 to 1 milligram sublingual during the first day, and then a little bit less the second day, and a little bit less the third day of changing a shift if you have a 1 week shift that is different from another. In oral melatonin can be that if you take on a 0.5 milligram orally, you might have to take 3 milligrams the first 2 or 3 days where you have a big shift change. But it's always before bedtime, not 3 or 4 hours after. That would be an error. If it doesn't work, it's that you need to give a higher amount, that's all.
Can melatonin be given as a long-term treatment?
Melatonin is already a treatment everybody has very long-term since the birth because we're producing melatonin. So if you take a hormone treatment, whatever hormone treatment, lifelong at the normal dose, you will not prematurely age your gland. You will not damage your gland that makes it. So if you stop making, you will make back the quantity of melatonin you made before starting in general. So it's very safe. It's even for testosterone. There was a study in rats male rats where they gave enormous dose of testosterone at young age, young adult age, and they continued till old age, and then they stopped the suppressive doses, so the disco didn't work and didn't make testosterone because there was so much testosterone. And then they made as much testosterone as young adult rats when they were old, after stopping the treatment, and they had the same sperm count, which is almost a miracle at that age of those old rats. So it's safe. It doesn't damage the gland. Of course, I'm talking about giving melatonin and other hormones at physiological dose. But melatonin, even at supraphysiological dose, is still quite safe.
Do you recommend use of time-release estradiol patch?
No. Time-released estradiol patch. With a patch, you have the first day not enough, the second day too much, the third day not enough. So it's more fluctuations. And then you don't know what is the right dose to give. You have always to change the right dose of progesterone, because estradiol has always to be balanced with progesterone, even if there's hysterectomy, because you still need to protect the breast from breast cancer with the progesterone and protect the mind from getting too nervous and from edema by progesterone, by natural progesterone, by identical progesterone, of course, not the synthetic derivatives that are toxic. So I prefer having a transdermal gel that you put on the arms, the full arm, and then the shoulder, and then it accumulates under the skin, and there's a 24-hour release gradually if you have spread in a thin layer all over and rubbed it sufficiently in. And then you gradually, from the fat tissue, it is released during 24 hours. You have a more stable levels. And that's easier to balance with progesterone because you have stable levels.
Could you share whether someone who has adrenal fatigue needs hydrocortisone before increasing T3?
Yes. So when there's adrenal deficiency, there are two options. There's desiccated thyroid or synthetic T3 and T4, which is contains T4 and T3, and for desiccated thyroid even more different thyroid hormones. And the other option is thyroxine only, but T3 is generally not an option in adrenal deficiency alone, T3 alone, because they have quickly intolerance to T3. So it's better that T3 is made from T4 slowly, and there's not too much T3 in these patients because they tend to very quickly convert T4 to T3. So if you give directly T3, they may also not tolerate it well. It's better than nothing, of course. T3, if you have hypothyroidism, it's the only treatment. Take T3, but you have to take it 4 to 5 times a day then. So I would rather recommend those patients that have adrenal deficiency either to give desiccated thyroid, and then you, before you increase the dose of desiccated thyroid, or when you start the treatment, you have to give hydrocortisone, because otherwise there's too quick conversion T4 T3. They will get at the end of the morning heartbeats and nervous and hypothyroidism. And they will not tolerate it and will say, you're a bad doctor or whatever. You didn't tell me that. So cortisol will really calm that down, those reactions. They will tolerate better. It increases the tolerance of many substances, including growth hormone, but also of the thyroid hormones. So start together, and if you increase the thyroid hormones and the dose is not enough for hydrocortisone, you have to increase the dose.
What is an overdose of melatonin, and what is a safe dose of melatonin to pediatrics?
Okay, so the overdose signs, I did give the most important ones. The most important one is really that it makes you sleep very deeply. So you think it's working well during 3-4 hours, and then you wake up because it has, at the end of those 4 hours, it has speed up too much the conversion of T4, T3, and you're sweating and your heart beats and you're nervous and you cannot fall asleep before 2 or 3 hours. That's the most frequent sign of overdose of thyroid hormones. And and the other dose can be that you have so much strong dreams that you don't know if it's reality or you're dreaming. It's really, it's almost sort of, it's not totally a nightmare. It's just like intense living or intense consciousness that you're dreaming or not dreaming. And then you have also this heavy head in the morning that's caused by adrenal deficiency. So if you have that, you have to back up. And most patients who are taking 3 milligrams or 6 milligrams melatonin have that sign. They're overdosed and they don't know. And the more they don't sleep, because they don't sleep the 4 last hours of sleep because of that, the more they tend to take melatonin, the more severe you have this overdose sign. Now, in pediatrics, that means in children, doses are relatively high. It can be as high as adults. I usually say it's the adult dose, even though they have a smaller body, because they usually have much more. And that high amount of melatonin helps them to sleep so calm and so relaxed, but also blocks puberty so that they grow longer. And so one of the ways of blocking puberty is having high levels of melatonin. And when the levels go down, slowly decline in children, then puberty comes up. So you can easily give orally 1 to 3 milligrams of melatonin to children, even 4 or 5 years old. And in sublingual, I would give on the average it's 0.1, but it can be 0.2 milligrams. It can sometimes be even higher than that. So you have to try. It's safe, but if they wake up in the middle of the night, you know, you have given too much, give a smaller dose. I always like to start low and then slowly increase till everything's corrected in sleep. And many children have melatonin deficiency. I know that my whole childhood was terrible. I had to read books in the night to really want to sleep, and I just had a melatonin deficiency. So it's much more frequent. It also can be caused by all the electricity around the head, wires, cables, Wi-Fi, and things like that, because that disturbs melatonin production. It decreases the melatonin production. So you have to keep children at night, at least away of all Wi-Fi and electromagnetic fields.
How do you dose your desiccated thyroid? At what serum levels of free T4 and free T3?
Well, studies have shown that you should be high normal for T4 and average level of T3. But studying that in blood tests is very difficult because when you just took the thyroid hormones, there's a peak level of T3 that's quicker absorbed than T4, and then a high normal level of T4. So you have the impression you're giving too much while you're not giving too much. And there's also suppression of TSH. So what I say to my patients, take it in the morning, but the day before the blood test, in the morning, you don't take the thyroid, take them after. And the only thing I really can see is that I'm not overdosing. If I have a blood test 24 hours, the last intake, generally the blood test, the thyroid hormones have decreased back to a low level again. But if they're high, I know that if they're high 24 hours after, I'm surely giving too much, a decrease. And the rest of the follow-up, I actually do by clinical examination to arrive to the right test. And one patient on 3 will have a decreased TSH below the lower limit and still be healthy. So that's in studies. Yeah, actually, of my patients, I have one patient in 5 having a lower TSH below the lower limit and acceptable. Because I give so many hormones that you don't need so much thyroid hormones that I rarely have a really suppressed TSH.
For menopausal women, would you give only oral progesterone without estrogen for sleep?
Only oral progesterone to menopausal women and no estradiol, or what? Is that the question?
Yes, if that person could.
I rarely would give to women only progesterone. I always give estradiol and progesterone because estradiol also promotes the sleep and is necessary to protect the heart, to get better bones and things like that. So I'll give a combined treatment, but the estradiol is given in the morning and the progesterone in the evening.
What is your preferred starting dose for DHEA in women who are low, and what is the preferred route of administration?
So the average dose in women is 20 milligrams, but in Asian women who are often smaller, the dose is a little lower, like 15 milligrams of hydrocortisone.
What is the difference between 7-keto DHEA and DHEA?
So 17-keto DHEA is a metabolite of DHEA that has the reputation of not converting back to DHEA. Nevertheless, I did have 2 patients on 7-keto DHEA where we checked the DHEA and DHEA levels were doubled. So there was a conversion back. I don't know if the reason was that the preparation of 7-keto DHEA was not pure and there was some DHEA in it, but I suspect there was a part of it was due to a conversion of 7-keto DHEA back to DHEA. And the reason why 7-keto DHEA is promoted with almost no study backing it is that it's considered cannot convert back to a female hormone or a testosterone, so it's safe in genital cancer. And so I do provide some 7-keto DHA because the risk is little, but it loses part of the efficacy. It has immune stimulating effects, so that looks good for 7-keto, but seems to miss the other effects of, for example, giving a better mucosa, so less dry eyes, for example, or slightly better muscles. And it might be less mood enhancing as DHA or less improve the quality of life.
How can you measure hormones given transdermally, estrogen if saliva testing is not available?
I don't recommend saliva tests so much because when treatment is given transdermal, there's a study showing that for progesterone, there's some abnormality with saliva. In the saliva, there's a sort of excretion of progesterone. You get very high levels of progesterone in the saliva, and you have normal or low levels in blood, in 24-hour urines, and so on. And also so it doesn't really reflect the clinical situation well. It's a sort of abnormality, secretion in the mouth of the sex hormones. So the best testing is blood test or 24-hour urine test. But still the clinical exam is important. The blood test of estradiol and progesterone are not so reliable. Why? Because estradiol is episodic secretion, and you can have from one moment to the other high or low levels. So it doesn't give so good an idea. And the progesterone there's no good binding protein, transporting binding protein of progesterone, so it doesn't stay long in blood. It goes quickly in the cells and accumulates there. Basically, I have a better idea of the amount of female hormones by asking blood sex hormone binding globulin. So the more estradiol there is, the more there is sex hormone binding globulin. If you work with transdermal estradiol, if the sex hormone binding globulin is at high normal, 65, for example, nanomoles per liter, that's an excellent value. You know you're probably doing a very good treatment because that's a very stable value. If it's 45, you're probably not giving enough estrogens. If it's very high, you're giving too much, or you have a birth control pill, which completely gives abnormal results.
Thank you, Dr. Hertog. We have time for about 2 more questions. I want to thank you so much for going over time. Dr. Hertog, what GABA products or supplements would you recommend?
So GABA, most patients need between 500 and 1,500 milligrams orally, and there are several different products on the market. I prefer always to work with tablets because with tablets you can take half a tablet, a quarter of a tablet, you can adjust. When there's too much GABA, and for example, I take regularly GABA when I'm in stress situations, so I sleep the night through without any problem. And but if I take it 4 days on a row, suddenly I want to cry. I become sad suddenly. And so it calms you. And in the beginning, it's fantastic. It's like walking along the beach. It's beautiful weather. Your climate is good. You have no worries. You really feel calm with that. So it's fantastic. Once in the beginning, when I was taking it, I had somebody extremely mad at me, and I was comfortable, no problem, didn't worry at all. So I could calm the things easily. And some people become then too calm and they become depressed with it, so they can only take it for 2 or 3 or 4 days on a row. And then there are some other people that don't only tolerate doses below 250 milligrams. So in these people, you need lower doses, and they have a sort of twinkle on the eye, very strange. Or they get also that depression effect or sad effect they have. It goes directly away, that sad effect. You stop one day and it's okay. But it's a good sign to know, yeah, I have to be careful. I cannot take on a constant level. Now, I must say, I have people that are intolerant to anything and have extreme anxiety with panic attacks. You can give as much GABA as you want in the morning, in the evening, they do fine with it. They can tolerate 3 grams per day without any problem. But I would always fluctuate. If things go much better, you can try lower dose, and if lower dose is also okay, you still lower dose. Any stress condition, you increase the dose. I take it also for jet lag. So when I go to the States, I'll always sleep at least 6 hours because I have a good sleep, partially due to a higher dose of melatonin and 5-HTP, but also with GABA. That will also be partly explained in the workshop, because I will talk about the sleep in several details, and you can always ask questions also. Yes?
Dr. Hertog, how much carnitine do you recommend per day?
Well, the dose that I recommend is 4 grams a day, because studies show that really improves the energy levels and has a very positive effect on your body composition. So it makes your body firmer. And I can tell I did just a career now for 1 month and a half, and I can see the difference. So why not take it? It's not dangerous, very good. If you take a lot, it can also decrease your thyroid functions. You might have to increase your thyroid hormones then.
Thank
Okay.
you. And our final question, is micronized progesterone protective against breast cancer like testosterone?
Micronized progesterone, if it's put locally on the breast in people who have, women who have benign breast disease or breast cyst, decreases the risk by about 25%. In the oral form, 50% in women who have benign breast disease. So it's really protective. There's a synthetic derivative of progesterone that also has a breast cancer protective effect because its structure is almost the same as a natural one. That's dydrogesterone. Dydrogesterone, also called Dufaston, and you can have in Mexico. I don't think you can have it in the States. I think you can have it also in Canada. Okay.
Thank you. Well, Dr. Hertog, we certainly appreciate your time and sharing your expertise. To the attendees, I did include the registration link, and we will be following up with an email. And for those who do register and would like to participate as being a patient for Dr. Hertog's workshop, you can email me directly. I'll put my email in the link. It will be Lindsay, LINDSAY @a4m.com. Dr. Hertog, do you have any final thoughts?
Well, final thoughts. At first, thank you for all taking the time to listen. I hope you enjoyed it. I really want to have a special thoughts for my team that's really working a lot. We have what I do is thanks to many people around me and many people in the world. And I really want to do a special thanks to the A4M that I really think does a fantastic job of promoting a lot of good speakers, a lot of good things, and altogether will grow the movement to a more ecological medicine that is patient oriented. I think we're on the good track. Thank you for attending. Have a nice day or a nice evening, depending where you're listening to.
Thank you so much, Dr. Hertog.
For helping as a moderator.
Oh, my pleasure. Thank you. It's been really fun.
Thank you.